So for today's program, Caroline Conway will be on, and she will be speaking about speech therapy and how that, how speech is affected by multiple sclerosis. All right, tonight's supporter, we have Genentech. Genentech is the company that supported tonight's program, and we all want to thank them, right? Everybody out here wants to say thank you. Great. Awesome. I do want to just welcome Caroline. She's going to speak with you about many things that even I need to listen to. So come on up, and nice for you to be here. She's going to speak for approximately 30 minutes, and then we will do a Q&A. So hold your questions, get ready, type them in online. You all in the audience, I hope you write them down too.
Thank you so much. I'm so excited to be here. Like Stuart said, my name is Caroline, and I am a speech-language pathologist. So I'm going to be talking to you guys today about a couple of different things related to speech-language pathology and how that intersects with MS. Okay, so just a little bit of background information about me. I graduated from Ohio State University, first with my bachelor's in speech and hearing science in 2019, and most recently with my master's of speech-language pathology. I have a specific interest in MS because my mom was diagnosed with MS in December of 2015. So since that time, I've been really interested in how my field intersects with MS, and specifically related to health literacy and advocacy as it relates to speech-language pathology and multiple sclerosis. So kind of a common theme throughout my presentation and some things that I wanted to talk about that Dr. Boster sort of hit on a little bit is being a self-advocate and being an informed decision maker. And I think specifically related to some topics that I'm going to talk about, oftentimes patients don't know that symptoms that they're having may actually be related to MS. And we'll talk about what that means in a second and some of those specific symptoms. So my role today is really exciting because I get to talk to you guys a little bit about some specific symptoms related to MS and give you the education and the information you need to be an informed decision maker and then go on to to get the appropriate evaluation and treatment. So first I want to give an overview about what speech-language pathology is. Some people may be familiar with speech pathology. Maybe you have a daughter or a son who got speech when they were younger. Maybe they couldn't say their R's or their S's, or you know someone who stutters. These are all things that people, that SLPs do and things that we treat. But related to MS, specifically we're looking at speech, so the actual way that we communicate, so our words, our language, so our understanding, so comprehending, and then also getting our words out, the expression, swallowing, and then cognition, so thinking skills, things like memory, problem solving, attention, all that good stuff. So this is kind of an overview of our scope of practice and some of the things that I'm going to be talking about today. Just a little outline of my presentation. First, we're going to be talking about dysphagia, then we're going to talk about dysarthria, and then we'll wrap up with cognition. So first we need to talk about what dysphagia is and what this means. So dysphagia is just the fancy medical word for difficulty swallowing. Now, dysphagia can present in many different ways. So we've all been there where we're eating or drinking and we feel like something is going down the wrong pipe and we start coughing and it's really embarrassing, and usually it is over in a minute or so and we all get over it. That's really normal. That's a normal variation of swallowing, and that happens to everyone. What's not normal is when this is happening a lot and when things are going down the wrong pipe and we're having that feeling really often. That's a sign that you're having difficulty swallowing. Some other symptoms of dysphagia include having a weak or wet vocal quality after eating or drinking, feeling like it's kind of like gurgly in your throat. Maybe difficulty chewing, so actually mashing up the food in your mouth or feeling like it's taking you a really long time to swallow, like it's really effortful to chew. Some other things we can see is trouble initiating a swallow. So maybe you've chewed your food up and you feel like you're ready to swallow, but it just won't go back. That is a symptom of dysphagia. And then also food getting stuck in your throat. So feeling like maybe things are just kind of stuck in there and they're hanging out. We can oftentimes see this with pills, especially for people with MS. Oftentimes people are taking multiple medications, oftentimes at the same time. So if you're taking, 4 or 5 pills at once and you feel like a couple went down, but a couple got stuck in there, that's a symptom of dysphagia. So now that we've kind of talked about what dysphagia is, it's important to talk about why this is important. So talking about dysphagia as it relates to MS is important for a couple of different reasons. The first being almost 50% of patients with MS experience dysphagia at some point in their disease progression. That's a lot of people. About 1 in 2 people will experience dysphagia. So being on the lookout for these symptoms is making you an informed decision maker and allowing you to advocate for your care. Secondly, safe swallowing is both socially important and medically necessary. Food and drink and eating and drinking are really social activities. Food and eating and drinking are things that are rooted in culture and tradition. You know, we all have our favorite family meals that we eat together, or, you know, maybe we see someone at the grocery store that we haven't seen in a long time and we say, oh, we should get coffee next week and catch up, or I'd love to, you know, get drinks with you soon, right? Food is very social. And if you're not comfortable eating and drinking safely, you may not participate in these social activities that you're used to participating in, and that decreases your quality of life. Secondly, eating and drinking and safe swallowing is medically necessary. We need to eat and drink to maintain our hydration and our nutrition. We know that people with MS often experience fatigue and weakness, and we don't want to exacerbate these symptoms by not having proper nutrition and hydration. So for these reasons, we really need to be talking about dysphagia and what we should do about it. So there's a couple of things that we can do to treat dysphagia in people with multiple sclerosis. If you're having any of the symptoms that I previously mentioned, maybe you're frequently coughing with your meals, or you notice that your vocal quality sounds different after, you're having trouble chewing or swallowing, you need to talk to your doctor about this. This isn't something to brush under the rug. And the reason why we don't want to brush it under the rug is because it can cause infection. The biggest thing that we're worried about is things going into your lungs. When you're aspirating food or liquid, and that's just the fancy word for things going into your lungs, it can cause infection, most namely aspiration pneumonia. And we know, obviously, people with MS often have a lot of other health comorbidities and things, and we certainly don't want pneumonia on top of that. What can happen is that food particles, instead of going down your esophagus into your stomach, they can go down your trachea, your windpipe, into your lungs and cause this infection. So if you're noticing that you're having these difficulties, please, please, please bring this to the attention of either your primary care doctor or your neurologist. And what they will do is put in a referral for a speech-language pathologist. So they'll send you to someone like me, and we will take things from there. The first thing that the speech pathologist will do is ask you about your symptoms and get an idea of what's been going on. And then secondly, they're going to order a swallow study. So this graphic here is from a modified barium swallow study. We abbreviate it MBS. And what it is a test that's done in a radiology suite where they have you come in and eat and drink different foods and liquids of different consistencies, and they see exactly what's happening. So you can see this person here, you see that huge thing kind of go down. That is liquid dyed with barium. So the barium is what makes it show up on the x-ray, and it gives us an in-depth look at where the food and liquid particles are going. So for this person, in general, things look good. They're all going down that back tube, your esophagus, into your stomach. But for people with MS or other different conditions, sometimes the muscles might not be working properly and your airway may not be protected. So we could see things falling into the airway. In terms of treatment, so say you go to your neurologist, you say, hey, look, I've been coughing a lot when I've been eating and drinking, I just feel like food's getting stuck. They send you to the SLP. The SLP does the swallow test, and then it comes time to treat. We need to do something about this. So there's kind of two different things that we would decide to do. The first would be offering up different strategies. So there's a lot of different changes that we can make you as the consumer, as the person who's eating and drinking, to allow the food particles to go where they need to go and to alleviate some of the dysphagia symptoms. So things like postural changes. So maybe making sure you're eating when you're completely upright at 90 degrees. Maybe we'd recommend that you use a chin tuck or a head turn strategy or a chin tuck. All of these different strategies are targeting different muscles and physiology that can be impacting your swallow function. Maybe we can practice training, taking small bites and small sips. Oftentimes, mealtime can be chaotic. We have a lot of people in the room. We might be talking to our family. We might be reaching for one thing and kids are running around, and we're not paying attention when we're eating and drinking. So training these strategies of making sure we're going nice and slow, being really mindful about our rate can be really impactful in making sure that things are going down the wrong pipe and that you're getting that nutrition and hydration that you need. The other avenue of treatment is a modified diet. So there's a wide scale of both food and liquid diet textures that can help with manage some of the dysphagia symptoms. So in terms of solids, we can start all the way at purees, so things that are like yogurt or mashed potato texture. There's different ground texture, soft and bite size, all the way up to regular texture. There's also thickened liquids, and these are for people who may have more severe dysphagia. Maybe things are grossly going into their airway. We can see on that test that things are getting in there. Maybe you've had a history of pneumonia and of chest infections. This might be something that we might recommend because it allows your body more time to react to these things rather than let those thin liquids drop down into your airway. So again, the treatment for dysphagia is going to be super individualized. This is definitely just an overview of things that could happen if you encounter these problems and see a speech-language pathologist. But just as an overview, these are some things that you might expect from working with a speech-language pathologist. The next thing that I want to talk about is dysarthria. So dysarthria is kind of an umbrella term for a motor speech disorder that can affect all aspects of speaking. So it can affect respiration, which is just breathing. So when we inhale, then we speak on an exhale. But for people with MS, when the nerves that innervate your respiratory muscles, if those are impaired, it may be difficult to time your speaking with your breathing. So that's something that can happen. We can also see difficulty with phonation. That's that fancy word just for talking. So we'll talk a little bit about that in a second, about how your vocal cords are supposed to beat together, and then what can happen when you have MS and how that can become impaired. Articulation, so the movement of your mouth, your lips, your teeth, and your tongue, all of these articulators move together really specifically to make sure our words sound crisp and precise. But oftentimes for people with MS, their speech can become slurred and kind of sound mushy, and there's a reason for that. And then prosody. So prosody is like intonation and that natural up and down that we have in our speech. When we're talking, it sounds smooth and it flows. But if your cranial nerves are impaired because of your lesions and disease progression, your speech might sound choppy or halted for a variety of different reasons. So again, some symptoms, kind of difficulty timing that breathing, that decreased intelligibility, so overall people not being able to understand you as well as they're used to, having an unusual vocal quality or a vocal tremor is really common, and then kind of like groping movements, slow lip, tongue, or jaw movements, which can make your speech sound imprecise. So studies suggest that dysarthria occurs in about 35 to 50% of people with MS. So again, that's a really high percentage of people. And what often happens is that, again, people might notice these things but not know that there are a whole group of professionals who are trained and eager and, ready to help you with these difficulties. And so if you're noticing that your speech is not sounding the way it used to, or oftentimes what can happen is that your spouse or caregivers may be the ones to pick up on it. You may not be the first person to understand or to notice these changes, but if you are picking up on those changes, or if they're picking up on those changes and can alert you to it, you certainly can receive treatment. There's a lot of different kinds of dysarthria, and they can all result from a different number of etiologies. So for example, someone who had a stroke is going to have a very different kind of dysarthria than a person with MS. So of course today we're just going to focus on MS, but it is important to be aware that there's a lot of different kinds of dysarthria, and this is mostly the umbrella term. But the two most common kinds for people with MS are ataxic and spastic. Ataxic dysarthria results from lesions in the cerebellum. So the cerebellum, they call it the little brain. It's this structure that sits right below the main cerebral cortex and above the brainstem in the back of your brain. And what the cerebellum does is it's really integral for these kind of online correction of planned movements. So when we're talking, again, a lot of things have to happen. We have to have our breathing, we have to have our tongue moving and our teeth meeting our tongue, and we have to sound clear and crisp. And when your cerebellum has lesions, oftentimes your speech can almost appear drunk. That's really what people say, is like it's that feeling, it almost sounds like you've had a couple of glasses of wine, but you really haven't had anything to drink at all. That's that ataxic dysarthria. Your speech can sound kind of strange and irregular. These articulatory breakdowns can just make it sound a little slushy. The other main kind of dysarthria for people with MS is spastic. And of course, this makes sense. We're all very familiar with spasticity and how this can impact your arms and legs, other parts of your body, but this can also impact your vocal cords. So on a typical good day, your vocal cords are beating together kind of like this. So they're supposed to kind of come together. But what can happen is that when you have spasticity in your vocal cords, they can get stuck together. So what can happen is instead of beating together nicely like this, they can get trapped like this, and the air can't get through. So your voice can sound really strained like this, because the airflow isn't happening naturally. Your vocal cords are experiencing spasticity. So just like you feel that tight kind of pulling feeling in your legs or arms, this can also happen with your voice. And it causes noticeable changes in your vocal quality. So being aware of some of these different symptoms is going to be really important to making sure that you're getting a proper evaluation and treatment. In terms of treatment for dysarthria, again, you're going to want to talk first with your doctor and say, hey, look, my speech hasn't really sounded how it's used to. My husband says that I sound like I'm drunk when I'm talking. I think this is a problem. What do I do? They'll send you to us. And what we're going to do is focus on two main things. One is improving overall speech intelligibility. So that's the idea that people can understand you. So we want you to be able to participate in conversations with your friends and family and loved ones, and we want them to be able to understand you. But we also have to do that in a way that preserves the naturalness of your speech. So again, for people who might be having ataxic dysarthria, their speech might sound kind of drunk and slushy and slurred. But if we can have them slow down, that could improve it. But if you talk like this, yes, my speech is very clear and crisp, but it didn't really sound very natural, right? No one talks like that. No one talks like a robot. So we as speech pathologists are tasked with this idea of finding this really good balance between these two things. So there's a couple of ways we can attack these ideas. Number one is targeting your breath support. So again, we inhale and we breathe on this nice, easy exhale. But if you have damage in the nerves that are impacting and innervating your respiratory muscles, this might be a little harder than it sounds. So we can practice and do exercises to target those muscles and rehabilitate their function so that breathing pattern is much more natural. We can be really mindful of when we're breathing and how we're breathing with our speech. We can target our speaking rate. So again, finding that balance between talking like a robot, and not going too quickly to where people can't understand you. So there's external aids such as pacing boards or metronomes, things that we can use in our therapy sessions that can help target these specific ideas of speaking rate, which can increase your intelligibility and naturalness. And then the last thing that I want to hit on here is augmentative and alternative communication. So AAC is anything that is not verbal speech. So I'm using AAC right now because I'm gesturing, and you are all using AAC as you jot things down, and you use AAC when you send emails and when you send text messages and when you wink at someone or use facial expressions. All of this is AAC. We all use augmentative and alternative communication in our daily life, but for someone with dysarthria who may be less intelligible, there's other options to increase their intelligibility and other modalities. Some people may be familiar with the use of iPads for speech. There's a lot of different speech generating devices. You may know someone who's autistic who uses a speech-generating device or has had a stroke. There's a lot of different etiologies for which this could be useful. And I will say that this is for people with more advanced disease progression with MS. It's not super, super common to use AAC with MS. However, these high-tech speech-generating devices are certainly an option for people who may have their primary lesions in that cerebellum or in the nerves that are responsible for their vocal cords. And then the last thing I want to talk about is cognition. So cognition is this fancy word for this range of mental processes that we use on a day-to-day basis. So things like memory, problem solving, attention, word finding, all of these things that our brain does without us having to tell it to do these things, this is cognition. And as speech pathologists, we treat this. So cognitive changes, as many people know, are a very, very common symptom of MS. And I think it's important to highlight that cognitive changes in MS are not linked with physical disability. So, for example, someone who is still working full-time and, walking and taking care of the kids could be experiencing severe cognitive changes, whereas someone who's a wheelchair user, might be sharp as a tack. So there's really no link between physical disability and cognitive decline. So this is something to keep in mind because cognitive decline can arise at any point in the disease progression. So it's not necessarily the first symptom that someone experiences, it's not necessarily the last symptom, but it can certainly pop up anywhere in the disease progression. And I say that because early recognition is key. Like Dr. Boster said, there's quite a few clinical trials that are happening for various medicines, but then also we can teach compensatory strategies. So in terms of treating cognitive decline, he talked about the one drug, modafinil, which is a fantastic drug. I'm not going to comment on that because I'm not a pharmacist or a doctor, but that is certainly something that is out there, but that's not in my wheelhouse. However, something that is in my wheelhouse is teaching compensatory strategies and teaching people how to live with some of the cognitive decline that they may experience as a result of MS. So there's a couple of different things that we can train and that we can practice in our speech therapy session. One thing that we can use is calendars. I know this might sound silly. These might be things that people have already used before, but I would encourage you, if you've not experimented with any of these compensatory strategies, to play around with them and see what you can do to help with some of this cognitive decline. So calendars obviously are a great way to keep track of things. I certainly encourage people to do or use whatever modality works for you, whether that's a Google Calendar, one on your phone, or a physical calendar. However, if you're not using any of those, I would encourage a physical calendar because physical calendars actually create a different neurological connection. When you are physically writing something down, that triggers a different thing in your brain than when you're just typing it on your phone. So having an actual physical calendar creates this mind-body connection, and it actually allows you to remember things better. So little tip and trick there. Setting reminders. Most people have smartphones, and the reminder app on smartphones is fantastic. I use it all the time. You can hit the side button on your phone and say, remind me at 5 p.m. to take the trash out. And literally it will pop up on your phone at 5 p.m., take the trash out. And it doesn't go away until you tell it to. So I use that all the time for silly things like taking the trash out or going to a haircut. I think using these external aids is really, really huge for people with MS, especially because you have a lot of appointments, you have a lot of things to get to, a lot of things to manage, and using these external memory aids is going to be really, really key. Another thing that we can do to treat cognitive dysfunction is remove distractions. So there's something called the cognitive hierarchy, and it's basically this long pyramid of cognitive functioning. And it starts at the bottom, and the bottom is sustained attention. So sustained attention is just literally your ability to be able to pay attention to something, whether that's pay attention to the TV or pay attention to your son talking or pay attention to your neighbor, whatever it is that you're doing. Sustained attention is down here. But recalling things is all the way up here. So it skips a lot of different parts of cognition to be able to actually remember something. But if we are trying to remember something, but we're distracted, we are significantly less likely to remember it. So if I say, Mom, I have soccer practice tomorrow at 3:30, but when I tell her that, she is cooking dinner and the news is on in the background and my brother is also talking to her, there's a really low chance that you're going to remember that I have soccer practice at 3:30 because we're not even having that sustained basic attention. So we're putting this demand on our body to remember something when we've skipped over all these cognitive hierarchy levels. We haven't even fulfilled the basic level of sustained attention. So by removing distractions, we're automatically training our bodies to remember things better. And recall and short-term memory is one of the primary cognitive deficits in people with MS. So by making sure that we're removing distractions, we're doing ourselves a favor to help increase our memory. The last thing that we can do is take a break. And I know this is hard. I think it's really, really challenging to say, you know what, I'm tired, I need to stop. But by doing that, again, you're being a self-advocate and you're treating your body better. So I like to call them brain breaks. And a brain break is when you take 15 or 20 minutes to step away from whatever situation you're in, go into a quiet room, maybe turn the lights off, and recharge your brain. Because when you're getting overstimulated, again, your body is being taxed, and our body is already under stress, and our body is already experiencing these immune responses that are atypical. So if we're experiencing atypical immune responses, and we're getting overstimulated because we're at a birthday party where there's lots of little kids running around, and they're trying to sing happy birthday, but Shelly wants to, open or eat the cake, and then this is happening, and lots of things are happening, our bodies and our brains are going to get taxed. So what we can do is go into a quiet room, take that brain break, let our bodies recharge, and then rejoin the social situation. Because that's our bodies telling us, hey, I need a break. And then we're much less irritable, we're able to sustain attention, we're not skipping on the cognitive hierarchy, and we're able to remember and enjoy that experience better. So I want to kind of leave you with this little kind of mnemonic device here. And I think that this is really helpful as a memory strategy. So the first thing, if you're trying to remember something, is to write it down. Again, we talked about that brain-body connection when we're writing things down. So the first thing I would ask you to do if you're trying to remember something is to write it down. The second thing is to repeat it. Say it out loud. Again, our bodies, whether we're an auditory or a visual learner, by saying things out loud and repeating it, again, we're creating this biofeedback. Again, that's the kind of fancy way of saying training your body is responding to itself, basically. So if I say, take the trash out at 5 p.m., I write down, take the trash out at 5 p.m., take the trash out at 5 p.m. So now I have that visual input because I wrote it down. I have kinesthetic input from my hand actually writing, and I have auditory input because I said it out loud. So there's 3 different biofeedback inputs for me to remember. Then I'm going to associate it. I'm going to try to think of something else that reminds me of this thing so I can remember it. So I like to use this strategy a lot with names. So maybe you go to a new doctor, and it's Dr. Smith. And you think, oh, Dr. Smith, that's the same name. My neighbor is Joe Smith. So now you're not going to remember your doctor, or you're not going to forget your doctor's name because Dr. Smith is the same as Joe Smith, your neighbor. Okay, so associating 2 things together, making those connections. Because again, with MS, your brain is under attack, but we're trying to preserve those neurons. So by connecting those neurons, we are preserving them. And then lastly, picturing it in your head. Okay, so thinking at 5 p.m., I'm going to take the trash out. Okay, like picturing in your head, I'm going to go to the side yard where I have my trash cans and I'm going to wheel it out to the front of the yard. Okay, so picturing these things in your mind can help us make these connections. These are some of my references, and I'd love to take any questions that you have about dysarthria, dysphagia, or cognitive decline.
Okay, thank you very much. First for your presentation, all right? And actually, there's somebody, Debbie online says, fabulous presentation. Many, many thanks.
Oh, thank you. That's very sweet. Thank you.
Okay, anybody here have a question? Okay, I know who's got a question.
With regard to remembering, I know a lot of the drugs people take in general can cause memory problems. There's a whole list of them available, not just MS drugs. So how do you tell the difference between the disease progression cognitive issues and the drugs causing the issues?
That's a really good question. And to be honest, that's like a little bit out of my scope. That would maybe be something that would be better to ask your neurologist. But what I would say would be being really mindful of the timing of onset of all of these things. So, if you start taking a drug and then 2 weeks later you notice this huge cognitive decline, I think that, there's a decent chance that maybe it could be due to this new drug. But if you've been on this drug for, 7 months, and then you kind of start to notice this cognitive decline, I think that would be more reason to be alarmed. And also being aware of how the cognitive decline impacts your daily life. So what events specifically is it impacting? So again, cognition is this really wide-spanning kind of term. So it's not just remembering things, but it's also word finding. So coming up with the right word to say. It's also problem solving a scenario. So, I got a flat tire, what do I do? If you're not able to problem solve that scenario, that's something to kind of think about too. So I would say in terms of teasing out the cognitive decline for a drug versus the actual disease progression is a really good question and something specifically to ask your neurologist. But from my perspective, I would say pay attention mostly to the timing. And then also too, once you talk to your neurologist, it's never a bad idea to get a referral either to speech pathology, because what we can do is, and I didn't really touch on this a lot, but when you get to us, we're gonna do an in-depth cognitive evaluation. And this is way more in-depth than you get in your neurology office. So obviously Dr. Boster talked about that kind of exam that you do, so the PEG test and then the symbol matching. I know everybody loves all those tests. So we do our own form of that, but it's like way more intense. And so we can give you specific information on actual different cognitive domains. So how is your attention? How is your memory? How is your processing speed? How is your word finding? And if it's only one of those areas that is impacted, that could be a question then for your neurologist of like, since I started taking this drug 2 weeks ago, I've noticed I've had a really hard time coming up with the right words to say. But if it's every cognitive domain, then I think that's also more reason to be concerned about the disease itself.
Thank you very much. Anybody else out here have a question? Do you have another? Nope. All right, next. This one person does.
I believe that all speech pathologists are not created equal. So how do you find someone who specializes in swallowing difficulties or dysarthria or the kind of cognitive issues you're talking about?
Yeah, that's a really good question too, because like you said, and kind of I talked about at the beginning, speech pathology as a field is very wide spanning. So, my best friend and roommate is also a speech pathologist, but she works with kids in a school, and that's very different than my job. And so in terms of finding someone who can really hit on these specific difficulties, there's a website called ASHA. It stands for the American Speech and Hearing Association, and they actually have a registry in there of different licensed speech pathologists and their specialties. And also for treating different things related to MS, you would want an outpatient adult neuro-rehabilitation facility, which I know that's a mouthful, but you're not going to be going to a school, and you don't want to pediatric private practice either, because most private practices only specialize in children, and not all of them, but many of them do. Especially, at least I know in the Cincinnati area. So looking for adult neurorehabilitation is going to be key. And a lot of those adult neurorehabilitation facilities are linked to major health networks. So it's very rare that an adult neuro rehab would be an independent facility. But for example, like in Cincinnati, like TriHealth or UC Medical are like some of the major health systems, or Christ Hospital, and those typically have their own neurorehabilitation rather than just independent facilities. But that's a good question.
Great. I'm going to take one from online before I get back to you. Okay, thank you. Kevin asks, so we should go to a speech pathologist before a neuropsych for cognitive disability can be diagnosed? What do you think?
That's a good question too. So neuropsych and speech, we have a lot of overlapping scopes of practice. And so neuropsychology, it also depends on what kind of a neuropsychologist you see, because there's specific like geriatric neuropsychologists, and they diagnose dementia and Alzheimer's and other cognitive decline. We do those tests too. It's a lot of overlap. I would say if you have more specific concerns of your cognitive decline related to drugs, then neuropsychology could be a better bet. But if you generally feel like it's just cognitive decline as a result of the disease progression, then come to us. And again, I know that's really hard to tease out, but that would be my stance on that.
Could you please discuss the impact of noises and the interference of thought processes and the inability not to want to do anything as a result of noise, impact on MS patients?
Yeah, that's a good question too. And so we kind of talked about this cognitive hierarchy, how, sustained attention is at the bottom, and then we have divided attention is going to be next on that hierarchy. So that's the idea that there is some sort of background thing that's happening, like noise, and that you're expected to do an activity. So maybe there's a train going by your house while you're making dinner, and it can be really hard to kind of manage those two things on their own. Another thing that we do see in people with MS, the eighth cranial nerve is your vestibular cochlear nerve. And when that nerve can be impaired, you can experience some form of like hearing loss. And so that's something to be aware of as well. But in terms of just overall cognitive functioning as it relates to noise, I think that comes back to that idea of removing distractions. And I know that's very much in a perfect world, is to say like, oh, I'm just going to remove the train. We can't really always do that. But trying as much as you can to manage your environment and kind of think through these things, especially a lot of noises like that are scheduled almost, or if like, oh, my grandkids are coming over at 4 p.m., I'm going to make sure I fold my laundry before they get here because I might not be able to do these activities when they're running around. So it's a lot of symptom management via environmental modification.
Thank you. Next one from online, regarding speech therapy and cognitive decline. Is there anywhere that there are clinical trials for this?
Yes, but so kind of similar to what Dr. Boster was saying, there's a lot of things happening with cognitive decline, but clinical trials oftentimes focus on pharmacologic treatments and actual drugs. The literature on speech therapy in MS is really interesting, and it comes back to the idea that a lot of people with MS are not getting adequate evaluation and treatment for cognitive decline as it relates to speech therapy. So what's happening is that people with MS are experiencing cognitive decline and nothing happens. They might bring it up to their doctor, but then their doctor doesn't know to send them to a speech therapist. So then the data that we have on our interventions is limited, and then it just starts this whole cycle over again. And so what I would say is if you're experiencing cognitive decline and you bring it up to your doctor, bring it up, because then they can make this evaluation. And there's a lot of interventions that are in the works and things that we have been doing in therapy, but because our sample size is smaller than we would like, it's hard to say how much we can generalize this information. But what we would like to do is get more people into our speech therapy sessions in order to see what interventions are the most useful.
Thank you. Next one. Can you please repeat the different types of dysarthria?
Yeah, absolutely. So in terms of MS, there's two main kinds of dysarthria. The first is ataxic dysarthria, and this relates to lesions in the cerebellum. The cerebellum is a little brain that sits on top of your brainstem, and it's important for balance and coordination and making sure things are crisp and precise. So people who often have balance issues typically have ataxic dysarthria, and what it results in is that drunk, kind of slushy, slurred speech. The second kind of dysarthria commonly experienced by people with MS is spastic dysarthria. Spastic dysarthria is a result of spasticity in your vocal cords. So instead of beating together nicely like this, they get stuck together and your voice sounds really strained or strangled.
Okay, I didn't know you were finished. All right, so going a little bit further though, who would a person best see if not a speech pathologist with regards to dysarthria?
We are the best people for dysarthria. We have very specific knowledge. We have to take whole classes on this. And then there's this whole other kind of aspect called like ear training. And so in my coursework in the master's program, we have to listen to many, many, many people talk. And we're not allowed to like see them, but we have to make diagnoses based on how they sound. And so when you go to a professional who's not ear trained, you could likely get misdiagnosed, and not only misdiagnosed, but then also they would give you incorrect interventions. So I would say come to a speech pathologist if you're having speech difficulties. It's in our title. Come see us.
Okay, thank you. Going back again for the same topic, I'm being asked, what is the form of therapy that you would do for dysarthria?
Yeah, good question. So it really depends on what kind of symptoms you're experiencing. So let's say that you're experiencing spastic dysarthria, where your voice sounds like this and it's really strangled. What we would do is a lot of relaxation exercises, and there is some efficacy too on like manual therapy, so like laryngeal massage and a neuromuscular electrical stimulation, which is really interesting as well. So it depends on what you're experiencing. So say you have that really strange, strangled vocal quality, that's gonna be really different than if you sound like you're having a really imprecise kind of slurred speech. So for that, we might practice saying phrases that are important to you. Maybe you really want to be able to say, I love you to your son, but when you say it, it comes out sounding really slurred. We would practice having specific articulatory targets, like, okay, we're gonna practice putting our tongue on our top teeth for, oh, I love you, something like that, but it depends.
Okay, what about the person who is not slurring their speech, knows exactly what they want to say, but it's not coming out of their mouth without a lot of stuttering happening, and they still cannot find the exact words to get from brain to mouth?
Yeah, that's a whole other thing. That falls under cognition. So that is going to be word finding. So word finding is actually one of the most common symptoms experienced by people with MS. I was just reading this paper recently, and it was a subjective survey and for people with MS, and this whole long list of symptoms was given in terms of cognitive symptoms, and that was the one that people rated the highest. And so for that, we're going to give you word finding strategies. There's this therapy that I really like called semantic feature analysis. And what it does is it trains your brain to come up with kind of related ideas to that one topic, so that when you're in conversation with someone, your communication partner can help guide you to the right word. So for example, if I want to say, my dog got out of the fence, but I cannot think of the word dog, and I'm like, it's, and I'm struggling and I'm stuttering and I can't get it out. My therapy is going to teach you how to get around that. So maybe we're going to practice describing, what it looks like, what it sounds like, what does it do, what do you do with it? So, it's my pet, that he's furry and he's funny and he's brown, oh, your dog? Yeah, my dog, and he got out of in the backyard, So I'm going to give you these strategies to help you articulate that. And also, it's also a lot of a caregiver and communication partner training. So not only am I going to work with you to give you these semantic features of this topic, but I'm going to also work with your caregiver and loved one to help them train you for how to react in this moment when you're struggling. Okay,
I'm just got one more to go towards this, all right? So the person that I was referring to knows what he wants to say, just can't get the word out. So it's not that he's looking for the word, he knows where the word is, he just can't get it to come out of his mouth.
So is it more of a speech issue or a language issue? So speech is like actually the words, like your tongues, your lip, your teeth moving. What I'm talking about is language. So that idea that it's on the tip of your tongue, but you can't get it out, that's language. And that's where we would bring in semantic feature analysis. There's also some things with phoneme features, which has to do with like the first word, melodic intonation therapy, that's using music to help get words out. It's hard to distinguish speech and language because speech is dysarthria, language is aphasia, and that's a whole other conversation.
So, which leads me to the question of, I have seen MS patients up to the point where they no longer can speak. So what form now is used so they can get the words out? Because before, I think it was typing in the information. I don't know if they still do that.
Yeah, that's a great question, and that's a topic that's very near and dear to my heart. So when we talked about alternative and augmentative communication, that's what we're talking about. AAC is any form of communication that's not verbal. And so for patients who have really severe disease progression and that may no longer be verbal, we have fantastic technologies now that can help these people. And so, for example, there's a lot of apps on iPads or other speech-generating devices, like the screens, that can help them get words out. So it may not just be typing, but there's whole programs that you can click a word, and then it can take you to other words because it's text prediction, and then it can take you to other words, and there's whole categories, and it's so fantastic. So for people who have who are minimally verbal with MS, there are tons and tons of options out there. There's also eye gaze technology. So say, they have limited range of motions in their hands for typing or for clicking on a screen. There's literally technology that tracks your eye movements and can choose words for you. It's amazing.
Thank you. Any other questions out there? You?
I have a question about swallowing. At what point do you recommend seeing a speech-language pathologist for a swallowing issue? What kind of frequency? If you're coughing twice a week, or if you're coughing once a month, at what point would you say someone should pursue seeing a professional?
Yeah, that's a good question, and that's something people ask a lot. I would say when the coughing or the whatever symptom you're having, the swallowing difficulty is impacting your mealtime, then you should contact a speech pathologist. So I would say if you're coughing or whatever the symptom is, maybe you're having trouble initiating a swallow, you're having a wet vocal quality, difficulty chewing, if that's happening at every meal, contact a speech pathologist. I would say if those things are happening at least 4 times a week, then contact a speech pathologist. This isn't just a one-off thing. This isn't I drank my Sprite too fast and then I started coughing. This is oh wow, things are really caught in my throat, and then I'm gonna go watch TV and it's still caught in my throat. That's when you should contact a speech pathologist, when it's impacting your quality of life.
Okay, thank you. Last question, okay? A person wrote in onto my phone, my father was diagnosed with Alzheimer's, but his memory is good. His speech is what was affected. He sees a neurologist who has not sent him to a speech therapist. How does he find a therapist who can to help his condition? He can't find his words or finish his sentences, and aphasia is what he has.
Yeah, that's a good question as well. So that's unfortunate that he hasn't received a referral. And again, this is my whole spiel here of why we need to have these events and do this education and teach patients to advocate for themselves. So it's hard because insurance is a factor. So it can be difficult. Like, this person could very much go on Google and type in speech language pathologist near me, but you have to have a referral. So going to either the primary care doctor or the neurologist and badgering them, literally saying, look, my dad or my friend, whoever is having these difficulties, I need a referral. And then they can put in that information and send you our way. But unfortunately, you do have to go through insurance, and that's a whole other conversation that I don't want to have because it's frustrating.
Okay, 1 second. I thought I said last question, but I think another one came in. Okay. Nora writes, here come the questions. All right. Caroline has so much enthusiasm and knowledge about the MS symptoms. Thank you. All right. Cindy writes, language issues comes out most often when I'm sick, like with COVID of a random virus that I need to see a regular doctor for. They never understand why I cannot speak and I cannot explain. I'm looked at like I am faking being able to talk. How do we educate doctors on these issues? She said, how.
Yeah. I wish I had a great answer, and my answer is that I believe you, and I know that you're not faking, because language is taxing on the body. So when your body is already under stress from COVID or a sinus infection or a UTI, the last thing it wants to do is have to come up with this thought and then move all these muscles and get it out. So your symptoms are real, and it makes a lot of sense because you're asking your body to do this task on top of already fighting an illness, on top of already having a chronic illness. So that is unfortunate that people aren't taking you seriously. And I hear you. The reason that I got so involved in this, aside, of course, from my mom having MS, there's a paper that was published in 2019 that looked at physicians and their knowledge of speech-language pathology as a profession. And all of the physicians that were surveyed, I believe there was 150 of them, only 2% ranked as having adequate knowledge of the speech-language pathology profession. That's a problem. That's why they aren't taking you seriously. And the education that we need to be doing is coming from events like this and talking with neurologists. That's why I love this partnership that I've developed with Dr. Boster, because he gets it and he cares and he knows the value in our services. But unfortunately, not every neurologist is as wonderful and fantastic as Dr. Boster. So as much as I don't think that it should be this way, you as the patient shouldn't have to do the education. Sometimes you might have to. And bringing these things up and saying, look, no, there's real evidence, and I'm not making this up, and there are professionals out there who specialize in treating this, is going to be the best way forward. But I'm sorry that you're experiencing that, because that's really, really frustrating.
Okay, thank you, Caroline. Thank you for coming out here today.
Thank you, I appreciate it.
We greatly appreciate it as well. Well, firstly, I want to thank everybody for being online with us, and I want to thank our sponsors, of course, and I did not get to mention that we had exhibit sponsors from Alexion, Banner Life Sciences, Janssen, Genentech, and TG Therapeutics, and I just wish everybody would, thank them all and be happy that they were all sponsors of tonight's event. And Genentech, of course, was the primary sponsor, and so we want to thank them. I want to thank everybody for being online and everybody that came to tonight's program, and so I'm going to say, join us. So again, thank you for everything, and we look forward to seeing you again.